This will be the last session until January 9th, when we come back after winter break for what will be a really interesting talk by Dr. Dean Winslow. On the lower left side of the screen, you'll see the QR code for CME attendance confirmation, so you can get MOC Part 2 credit. On our next slide, we have our Stanford University land acknowledgement. This is where we would like to recognize the university sits on the ancestral land of the Muwekma Ohlone tribe. Consistent with our values of community inclusion, we would like to acknowledge and honor and make visible the university's relationship to Native people. Another important announcement as we move into winter break, the abstract submission deadline for the 15th annual Pediatrics Research Retreat will be on January 22nd. It's about a month away now, and the retreat itself will be in late April. If you haven't been, it's a great time where we get to enjoy the sunshine and enjoy great research from the department. And with that, I'd like to pass it over to Dr. David Kornfield, who's the Chief of the Division of Pulmonary Asthma and Sleep Medicine, to introduce our speaker today.
Thank you so much. It's a real pleasure to be able to host Grand Rounds speaker Samuel Goldfarb today on behalf of Pediatric Pulmonary Asthma and Sleep Medicine. Dr. Goldfarb comes from the land of Minnesota and 10,000 lakes, and he was kind enough to brave the snow to come to the rain, so we're happy to have him here. Sam is now the CF Center Director and the Marzotto Chair of Pulmonary Medicine and Cystic Fibrosis at the University of Minnesota. Prior to that, Dr. Goldfarb spent about 20 or so years, 18 years, at the University of Pennsylvania at Children's Hospital of Philadelphia, where he was one of the pulmonologists and the director of the lung transplant program. Dr. Goldfarb did his fellowship at Children's Hospital of Philadelphia, and prior to that was at the Yale University affiliated residency program in Bridgeport, and did his medical school at Sackler Medical School in Tel Aviv. I'm really happy to have Dr. Goldfarb here. He's really widely acknowledged as one of the national experts in stem cell related lung injury. He also is acknowledged as an expert clinician and really one of the long-standing contributors to the medical management of pediatric lung transplantation. So without any further delay, I'd like to welcome Dr. Goldfarb to the podium. Thank you for coming, Sam.
Thank you, David, for this kind introduction. And the weather here is, I know you guys, everyone's apologizing for the weather. My wife texted me, she said, don't talk about the weather. It's 16 degrees here in Minnesota. But so what I'd like to talk about is pulmonary complications of stem cell transplant. What do we know and what are the next directions? And before I get started, just some conflicts of interest in regards to advisory boards and funding. And then so this is kind of what I'd like to talk about. I think it's not that all roads lead to pulmonary injury and stem cell, but those are the patients that I end up seeing, right? So 100% of the ones that come from stem cell who have lung disease are the ones that I end up seeing. And that's not to say that every patient has that. But so I'd like to just give two illustrative case histories, talk a little bit about radiation and chemotherapy, lung injury, some of the early complications I'll gloss over just to give you the background, but not necessarily to harbor on them. And then I'd like to talk a little bit about more late complications, chronic GVHD of the lung, and what directions I've been involved with in working and had the pleasure to work with some pretty smart people. So this is the first case is a 10-year-old with a history of sickle cell disease. She was transplanted because she'd had a stroke and she had some acute chest. Some of the history is not very clear. She was adopted when she was 5. And then so from a pulmonologist standpoint, we looked to see, what her lung function was, and they'd done her spirometry the day after she had a G-tube placement, so they were not really very helpful. She had her first transplant on 10/21, in 10/21, and unrelated 7 of 8 BMT. This was her conditioning, and then about 2 months later, graft failure. She went with the same donor for a second graft with a little bit more, so they used busulfan and TBI. And she was on GVH prophylaxis for the first year according to the protocol, which is mycophenolate, and then they continued on sirolimus, and then the second one was mycophenolate, and then tacrolimus, which was tapered about in August, and I met her in December. So she presented about 12 months after her first transplant, and she'd been a little bit lost to follow up. And according to the score that I took out of her patient note, she had one thing that was very noticeable. She had significant weight loss. She had skin disease, mouth, eyes, GI tract was 0, but her liver, she had elevated bilirubin, and her lungs, she had shortness of breath, but we didn't have a clear diagnosis. She wasn't able to do PFTs at the time, and she came to see me. And this is what her film looked like when she presented. And it looks kind of non-specific. They called it maybe viral, a little bit of interstitial. You can see on the left side, the kind of what was characterized by the CT. There wasn't a lot of like hyperinflation or mosaic pattern, but it was interstitial. And so she was admitted more so to help us figure out what her lung disease was like, but also because she had significant weight loss and poorly controlled chronic GVHD. And so we started our workup, and we, with that, we did serology testing. She was negative for all viruses. She did have EBV and CAV PCRs that were positive, but very low numbers and not thought to be driving it. We did a couple bronchoscopies, so we looked at 16S and 28S, which both were negative. Her bronch revealed lipid-laden macrophages was very nonspecific and not very high. She had a normal echo, and when we were looking for the thought of potentially TMA, thrombocytic microangiopathy, her value for the SC5B9 was mildly elevated, but not significant also. And just in her bronch, I just illustrate that it was probably nonspecific. There was no increased neutrophils for the most part, and we had done 2 bronchoscopies. Her film started to get a little bit worse though, and this second bronch was based on this. And you can see she had kind of a peripheral pattern. So I was thinking maybe she had previous ischemia or infarcts or whatever, and we weren't quite sure. She continued to progress. At this point, she wasn't intubated, but on supplemental oxygen. And then here, just a couple days later, she had significant worsening and required mechanical ventilation. And her chest film and her CT both continued to progress with this kind of diffuse pattern, mosaic pattern, not necessarily hyperinflation. So she was treated with, according to the protocol there, methylprednisolone at a relatively low dose for the pulmonologist in the room. And then when I got involved, I recommended that we pulse her, thinking that it was probably GVHD of the lung too, because she had it in multiple places. She was restarted on tacrolimus, and then ruxolitinib was started. And she had been treated with a drug that I was less familiar with for her liver disease. And then because she was progressively getting worse, we treated her with eculizumab also for the thought that she might have TMA. And this is 1 month later, she had progressive failure and developed an air leak, and you can see in this, and was on an oscillator for about 30 days, and ultimately we withdrew support. And what was not interesting, but what was one of the things we learned is they did do a post-op, and the pathology really just revealed severe diffuse alveolar damage and no GVHD of the lung at all, and she did have GVHD of the liver. So it was very confusing to us that she had developed such rapid and ongoing lung disease, but it didn't really quite fit the pattern that we were thinking of. And so this is just one case that I'm thinking that is unusual and unique, but probably a lot of the cases that we see. And this is just another kid, and this is a dynamic MRI, and this is a patient who had restrictive lung disease. She has a history of neuroblastoma at the age of 3. She was treated with cisplatin and etoposide, vincristine, cyclophosphamide, doxorubicin, ifosfamide, and a lot of radiation. And you can see the only thing that was moving was really just the diaphragms. Her chest wall was completely fixed. And so I met her when she was probably about, 9 or 10, and she lived to about 20, but she ended up dying of severe restrictive lung disease. And so this is just one of the complications that we see. And this one is different. It's an auto transplant as opposed to allogenic. But both of them always raise the question to me how important it is to understand what's going on. So I think just in general and very briefly, leukemia rates in pediatrics are probably 30%. They're less than the adults. Survival rates are improved. And this is due to chemotherapy, radiation therapy, and stem cell transplants. And stem cells in general over time have increased in numbers. And you can see that auto transplants actually surpasses the allogenic, and it's for multiple different cancers, or and then allogenic I'll talk about briefly after, but the indications are changing over time, and more of them are being done, which just means that percentage-wise, pulmonary medicine is getting involved because a lot of these patients will have pulmonary complications. And this is just a quick review. So pulmonary complications, childhood cancer, you can have early and late complications from chemotherapy, and stem cell transplants has its own vast array of early and late transplant-related illnesses. And so when I see a patient, it's always important to me the diagnosis that led to their stem cell transplant, what therapies they might have received, and then what kind of complications might have happened prior to their transplant. And so to me, I didn't understand anything about radiation therapy. And I bring up these two slides because it's like radiation 101 and what it means to the lung, essentially. So radiation injury, well, generally we know that it breaks the chemical bonds and causes free radicals. And then these free radicals interact with the DNA, and this was what is the desired outcome, and a little bit less with some of the other things like lipids and proteins in the cell. And then how would it affect the lung? So in the lung, radiation is non-discriminating, so it'll go after pretty much anything that's there. And there's different types of cells in the lung. So type 1 pneumocytes are terminally differentiated and don't undergo cell divide, so they're relatively radio resistant. And then there's the ones that the other cells, the type 2 pneumocytes and endothelial cells, which are more susceptible to lung injury. And these are just two images. One is more focal and one is more diffuse. And we don't see this quite as much in a lot of the stem cell transplants, but we do see it in other disorders or autologous or auto ones, particularly for kids with like Hodgkin's disease. And so to me, what's important is not so much if they, once they get it, it's the process, right? So where am I seeing them in the timeline that they've had their radiation therapy? And why is that important? Because they might have had radiation therapy, then gone on to a stem cell transplant. And I might see some of the effects of that, or should be thinking about those effects 3 or 4 months down the line. So it is a timeline of injury, and there's acute injury that happens in the first hours, which might be kind of an edematous. Then there's acute phase with maybe hyaline membrane, and then as you get further on, it goes on and leads on into fibrosis. And you can see in this, and there's various upregulation, downregulation, pro-inflammatory, pro-fibrotic pathways that are initiated. And so it's always a cross section. And in my mind, I'm trying to think of where they are at which stage. And what we learned, and this is from the group in, I want to say in Pittsburgh and some others, that this is just talks about the age that patients get irradiated, and then what the significance of the findings. So the younger you are, the more likely you're going to have interstitial lung disease or obstructive lung disease, or a combination of both. And the one on the left side, left for you, yep, breaks it up by age, and the one on the right breaks it up by whether it's whole or partial. And I guess you can estimate that the more radiation you give, the more you're going to have damage. But the takeaway is really probably the time frame. So think of the kids that are under the age of 5 who receive radiation. It impacts their lung disease is impacted much more than someone who's 13 or 14. And I think that's also more common in the adults. They don't always see the same things that we see in pediatrics. So chemotherapy is not benign. I think with any kind of induced lung injury, and the point of this slide is it's very nonspecific, right? So they could have a cold, or they could have busulfan toxicity, and you're not going to really understand the difference. And the question is, can you look for it? And so in some cases, we know that certain drugs, BCNU, methotrexate, bleomycin's the classic one that causes interstitial fibrosis. And then there's some of the other ones, busulfan and methotrexate for that, and even cyclophosphamide, which is used for some things, but can also have some of the side effects. And we talk about acute and late toxicity. And I'll just briefly talk about 2 of the different drugs, but busulfan is one that's used a lot in stem cell transplants. So my idea is we should understand what the toxicity can be. And it's not very high, but it still exists. And when you have a patient who's received that and comes in 3 weeks later with acute lung disease of some form, it can contribute to diffuse alveolar hemorrhage or pulmonary alveolar proteinosis, for example, or even forms of pneumonitis. And the same with cyclophosphamide. It could, early and late exposure, and cyclophosphamide is used a lot as a prophylaxis for GVHD, and it's used in other interstitial lung diseases. We've used it to control both T cell and B cell components, but it's not a benign process or a drug. And when combined with either supplemental oxygen, radiation therapy, or other medications, the risk for complications increase. And then BCNU, the only reason why I bring this up is because I didn't understand that it ever really caused lung disease. And this was a patient that was their primary or presenting or pre-transplant PFTs. And then this is what it was just a couple weeks later, and they had developed severe significant disease that based on the oncology team or the BMT team said that the only drug that he had received so far, I can't remember exactly which protocol it was BCNU. And then we stopped the med and it improved. So not entirely, but it was enough that we could correlate the difference between the two, the correlation between the med and his lung function. So I always think about pre-existing conditions are important to understand, what they've had for radiation and chemotherapy, and what other complications they might have had. So different people have done different studies, and this is a group from CHOP that predates me just a little bit in the research that they had done, but they looked at all the PFTs in 270 patients pre-transplant. And this is what they found. And you can see in regards to what I've highlighted in red is that diffusing capacity, so that's the way oxygen goes across into the lungs, only less than 40% of the patients had normal diffusing capacity values. And when it came down to the other ones, spirometry, only 80% had normal. Static lung volumes in this one, only 90%. So it was interesting to me that they're coming to transplant. Many of them are coming to transplant with abnormalities. And this is a score that people don't use that often. It's called the lung function score. But basically you take the FEV1 and the diffusing capacity, and you figure out what their value is, and you add up the values. So if both of them had under 60%, there'd be a score of 8, and they categorize that into different ones. And this slide just illustrates the morbidity and mortality, or the mortality essentially in the Kaplan-Meier curves. That the ones that are had a very mild lung disease did well, and the ones with the more significant categories had increased mortality. And then just one more to hone in on this is a group from St. Jude's, and they had retrospectively looked at about 410 patients, and they found that out of them, 42% of them had pulmonary complications, and they found that the complications were associated with lower levels in their PFTs, T cell depletion, acute graft versus host disease, and then chronic GVHD. And their mortality rate was 2.8-fold increase with patients who had pulmonary complications. And then it was significantly related to, in this scenario, lung function testing that were all below the 50th percentile, along with T cell depletion. And then worse survival was also noted with essentially worse lung function. So what we know is when someone goes in, they're at higher risk. If they have abnormal lung function, they're at higher risk. And I recognize from then until now, pathways for stem cell transplant and how they do them have changed, but it still puts them at greater risk. So now I'll just talk a little bit about stem cell transplants. And all of that in my mind is a story, right? So you have the case where you don't quite understand why the first girl died from something that wasn't exactly GVHD that we all thought it was. And then I kind of like put together what happens with chemotherapy and radiation therapy and how that impacts. And each, someone who's coming for a stem cell transplant from a SCIDS, for example, is different than someone who has a leukemia. And those are just two examples. So then it brings me to, okay, now we're at the event of stem cell transplant. And stem cell transplants, and this is basic 101 for a pulmonologist. So I borrowed these slides from a friend of mine who's a BMT doctor, and he kind of walked me through. So autologous stem cell transplants, high dose chemotherapy, stem cell rescue. You do a lot just to push the chemotherapy on the marrow's ability to recover. And you can see the words are meant for pulmonologists so we can understand them. And then it's used a little bit in gene therapy or orthoscopy, and then common indications seem to be neuroblastoma, brain tumors, and Hodgkin's lymphomas. And so this is one population that I'll talk a little bit about the study that we're doing now, and this is a field that we'd like to also include in our study moving forward. And then there's the allogenic, which is meant to cure cancer and bone marrow disease. You replace a faulty system and then create new immune system. And the most common, or what we used to think of, was just for malignancies, and that's one pathway. But there's a huge indication for non-malignant ones, and some of them are like aplastic anemia, Blackman or diamond, Blackfan, Schwachman diamond. And then there's inborn errors of metabolism, as you guys can see, primary immunodeficiencies, hemoglobinopathies, and then lymphoproliferative disorders and whatnot. And this is just one portion. There's always more. And like at the University of Minnesota, they do tons of hurlers, and they'll do, not tons, but they do a lot. And then adrenoleukodystrophy is like one of their prime areas. So it's like learning a whole new subset of disease and how it's affected. So this is just me trying to understand what happens. So which type of stem cell transplants, and this is important to understand what the complications might be. So matched sibling clearly, I think, is some of the best outcomes. Matched unrelated donor, in some cases, you can have a higher risk for GVHD. Cord blood cells is good, but it's also limited in volume. So how you can give and what age you can give. And then haploidentical, which I know here you guys have done a lot of great work with, but in some of the patients that I've seen at other sites, they're the ones that seem to be at greater risk for GVHD. And then you can manipulate the graphs. And this is, I put this slide back in after talking with you overnight because I didn't want, or last night at dinner, but there's different ways to manipulate to try to decrease either, T cells, or how to diminish the role or decrease the risk for GVHD. And there's depletion of the alpha beta T cells that you guys do here very successfully. At Minnesota, they do some of that, but they do more cyclophosphamide in the time frame prior to, and you can see a little timeline down there on the lower right. So these are just different techniques. In that case, despite all this, it's still not 100% perfect. And some sites will have higher rates. And I know that T cell depletion, traditionally, if they did more straight on, then the patients would have more infection risk. And if they had increased T cells, then they obviously had more GVHD risk. And then there's the different types. And so I'm clearly not a BMT doc, and I don't decide this, but it's important to me to understand which regimen's being used and what my risks are for ongoing lung disease after. And you can see there's myeloablative, full intensity, all the way down to someone with SCIDs where I guess there's not a lot of conditioning, it's just stem cell dumping. So now this is the pulmonary component of it. So there's different complications that can happen post-stem cell transplant. And this is where things get murky. There's some patients that it'll happen shortly after, and it's a fairly benign process. And there's others that end up in the ICU setting. And then there's some that go home and everything's great and show up in our clinics, 6 to 8 months later. The bottom portions of infections, I'm really not going to talk that much about that. That's a whole other process. And but clearly bacterial, viral, and fungal, and most of these patients go home on some form of prophylaxis, or it's addressed rather early when they have fevers. But from a lung standpoint, it's interesting to understand where the process or the disease can happen. So whether it be pulmonary parenchyma, airway epithelial, or vascular endothelial. And this is a review that was done several years ago, and it still stands to reason that as you're thinking about lung disease, it's important to understand in what venue it can happen. And I think from a pulmonologist standpoint, we often don't think as much about the pulmonary vasculature, and I think that's important to do also. And this is a slide I took from Ken Cook, and this is his way of dealing with it, and it's whether it's early within the first 120 days and then late complications. And I'll go through them just a little bit. But this slide kind of talks about, it's important to show that early complications can be related to chemotherapy or radiation therapy, transfusions, and then you have capillary leak syndrome, peri-engraftment syndrome, diffuse alveolar damage, and all kind of a constellation of idiopathic pneumonitis or pneumonia syndrome. And then the bottom portion is more the late effects. And I'll talk a little bit more about that because the study that we're doing is more geared towards identifying those and understanding them. So IPS is peri-engraftment syndrome, diffuse alveolar damage or hemorrhage, acute interstitial pneumonitis, and delayed pulmonary toxicity. And some of these, unfortunately, have very high morbidity rate. And there's a couple studies in, was it TNF-alpha blockade and steroids versus just steroids, and which one works better and which one's not. I think my goal is if you can avoid them, that's probably the best thing. Not the treatment, but just the underlying what happens. So, and here again, you can kind of refocus on where the site of injury is. And because I do research with Cincinnati, and this is their baby, and they like to talk about TMA, I'll give them their 2 slides. But it's an interesting concept, and I think I've run across it a few times, and it's never been completely the way I thought from a diagnostic standpoint. It's very similar to Henle-Schuller's purpura, or with microscopic thrombocytic angiopathy. And there's a pathway here, and there's a way to diagnose it. And what we've seen in patients is that they have pulmonary, they can develop pulmonary hypertension and hypoxemia, and it can happen at a time frame. And here's some of the slides that you might see when you look at the lesions, where you can see thrombosis in the vessels, advanced obliterative lesions, denuded lesions. And it generally is thought to be related to kidney disease and lung. Can there be lung alone? I think twice I've seen it, and both of them have been complicated by one patient had severe restrictive lung disease or interstitial fibrosis secondary to previous cancer therapy and radiation, and had components of TMA and did not have renal disease. And the second one was also similar and had some other components. And whether it was that or not, it's still a disease process to look at. And I think there's still more understanding that's needed. So the late non-infectious pulmonary complications kind of get broken up a little bit differently. Bronchiolitis obliterans versus bronchiolitis obliterans syndrome. The difference is one is a pathology diagnosis, obliterative bronchiolitis, and the BOS, the term that's used, is a clinical diagnosis based off of lung function testing or imaging and clinical history. And then there's the interstitial lung disease component, which is not quite as big, but organizing pneumonia, formerly known as BOOP or COP now, and other interstitial lung disease. And there's pleural parenchymal fibroelastosis, which some centers seem to see. So I'm going to talk briefly about the first 2, then the rest will focus on the upcoming research and stuff. So organizing pneumonia is not the same as bronchiolitis obliterans. The pathology here is actually in the alveolar cells, and it's interalveolar connective tissue plugs, essentially. From an imaging standpoint, it might be more difficult to look at or to discern the 2, because they can look similar. You can have a mosaic pattern. You can also have hyperinflation to some extent. The timeline is anywhere from 2 days to 7 years, but generally within the first about 3-month time frame. There's an association between organized pneumonia and chronic GVHD. And then the lung abnormalities mainly consist of ground glass opacities and consolidation, and is generally treated with steroids, and that's actually a good thing. And this is what the pathology might look like, and what I've tried to identify here, and here are the different plugs. And so it often, I guess the question is there, only because they have organized pneumonia and bronchiolitis obliterans, people can sometimes think of them as being one and the same, but they're different. And the treatment's different. And BOOP versus COP, I think COP is the more updated terminology for it. And it sounds cool, but so does BOOP, so I guess you can pick. And then this one, pleural parenchymal fibroelastosis, that's pretty rare, but it makes me think of the kids that the neuroblastoma kids with the restrictive lung disease and severe and significant fibrosis that we see where their chest walls don't move. This can happen in both stem cell transplant, but it can also happen in solid organ transplant, particularly obviously lung. And in some of the cohorts that they've described, it's been associated with chemotherapy agents, alkylating agents in particular. It does have some characteristic findings. So you can see in the upper lobes up here, abnormalities, and this is a fibroelastin complex. Unfortunately, the chest generally freezes up, and then in some of these other imaging, you can see it becomes more advanced, and survival from this, unfortunately, is not very good. The treatment for it is also not very robust, and patients who can have a lung transplant generally need to have it earlier as their chest wall in the scenarios that have been described become also very fibrotic. Okay, so now I'm going to focus and shift a little bit. So all that brings us to here, right? So I think that chemotherapy, radiation therapy, and early complications probably all have some role in what happens later. And if they don't, that's good. But if they do, we want to understand it a little bit better. I want to know if someone has VOD, if that increases the risk long-term for pulmonary complications, or if they have a touch of TMA, or if they have, this combination plus an infection with, I don't know, adenovirus. Does that going to put them at greater risk for developing chronic graft or chronic GVHD? So GVHD is, and I don't want to try to teach it beyond what my knowledge base is, but what I do understand is that it's, there's host-presenting cells, then activated donor T cells, and then and it's an aberrant pathway of upregulation of different cell lines, and what we know, or what everyone in the room knows, is skin, mucus, mucosal, gut, liver, lung, and more. What I was always taught that it seems to in cells that turn over faster, it seems like there's more of a increase. You'll see it earlier, and you'll see it potentially more often, and that's why I think lung, when it becomes involved, is generally a later process after there's either other GVHD or even on its own. It doesn't develop in the same timeline as some of the other acute GVHDs or GVHD in general, chronic. So that all depends on the degree of match, T cell depletion, and other things that go into what we just talked about, what type of cell type or what donor type, what chemotherapy regimen, what prophylactic therapies have been used. And so one way I look at it is, can you get from A to B without having complications? And this is just one slide that I kind of thought was pretty neat, this schematic, and it kind of talks about how you get from how you want it to work the right way. So you have normal or homeostatic expansion of the thymus and good education, and it understands what to do, and you have a good response. Or you have a response that, and I'm going to just talk about it very briefly, like either your adaptive T cells or whatnot, and then they kind of alloproliferate in the wrong direction, and you end up getting immune dysregulation, which is a very wide or broad term, but it means that your immune system didn't do what you want it to do, and it pushes you in the direction of immune dysregulation. And then, so there's different stages of it, right, of chronic GVHD. There's the early inflammation, and the point here is not to talk as much about the therapies for it here, but just in general, you have host antigen presenting cells, you have donor T cells, how they interact with the graft, and then you can have thymatic injury, T cells and B cell dysregulation, and chronic inflammation, and all this leads into a process of tissue repair and abnormal function, and then along with fibrosis. And here you can point out there's different medications thought to have different effects at different timelines, whether it be rituximab or ibrutinib and JAK inhibitors. And there's thought to be pirfenidone, for those that don't know, is an anti-fibrotic medication used in interstitial fibrosis in some scenarios, and it's thought to have some effect on TGF-beta. But so this is what the manifestations of chronic GVHD is of the lung. And so people say chronic GVHD of the lung or bronchiolitis obliterans. I think what we think of as GVHD is the mechanism and the finding. The pathology would be the bronchiolitis obliterans. And so it's like a little pause, but one thing that's to me is very fascinating is bronchiolitis obliterans, or BOS, however you want to call it, can develop from GVHD from stem cell transplant. But it's also the leading cause of death for lung transplant recipients. So there it's instead of graft versus host, it's host versus graft. And it probably all has to do something with manipulation of T cells and whatnot. And then there's a cohort of patients that develop what's called PIBO, which is post-infectious bronchiolitis obliterans. And that in generally is caused by adenovirus. And in certain clusters of communities, so it's more common in South America and Central America. And then it's also more in some of the indigenous tribes that live along in Mexico and further down. And I did travel once to China, and we gave a similar grand rounds, and then they presented patients, and they didn't have cystic fibrosis, which I was used to, but most of them had, a lot of them that they came to visit had bronchiolitis obliterans. And I do think that there's some genetic susceptibility to it. And then the understanding is that why would someone go along that pathway? It probably still has to do with some immune dysregulation that they have. So I think all of these are intertwined and lead to a common pathway. And to be truthful, I did a lot of time studying bronchiolitis obliterans in lung transplant. And then I started to get exposed to more of the stem cell transplant. And I thought that the stem cell transplanters had a better understanding of the immunology and the manipulation of it. And they also had better drugs, which I'll talk about because we just use steroids and you have a whole slew of them. So then bronchiolitis obliterans, just a little history, probably was first diagnosed in the early 80s as a cause of the product of graft versus host disease. And then onset is anywhere from 100 days to 2 years, which is important to think about. It can be a little bit longer than that, but that's the time frame that we want to monitor it. It's definitively linked to GVHD. What I said before, the diagnosis is OB, or obliterative bronchiolitis, on biopsy, and BOS is just a clinical diagnosis. And so this is the pathology that you see in general. So if I think I can do that. So this is what a normal lung would look like, the bronchial. And then here you can see that it's narrowed and it becomes essentially obliterated. The schematic here down here shows that. And it's a terminal bronchi. And then you have the alveoli beyond it, which is generally not diseased, only the fact that if it doesn't receive ventilation, it becomes scarred, or some will be hyperinflated and some will not be. And some they become obliterated, I guess. And then on the right side, you can see the different things that you might see on a CT, and you can see sometimes dilated airway. Down here, they're talking about tree and bud, which is really mucus impaction. And then there's areas of air trapping versus not. And so that's what they call the mosaic pattern. And then how do we make the diagnosis? And in general, we think about it as a clinical diagnosis. We think of their symptoms, think of different imaging. Lung function testing, if they can do it, is very appropriate, and sometimes lung biopsy. And so just to show you how significant it is, this is the obliteration. So this is, there's something called bronchitis obliterans, which is larger airway, but this is done with a ultra-thin bronchoscope, so it's 1 millimeter in diameter, and they can go down to the distal airways. And this is one of the findings that you see. And I did see this in lung transplant recipients, and you try to go through it and you can't. It's like, it's a big fibrin. And then just some of the more proximal ones. So this is ones you can see just in a regular bronchoscopy. And this is courtesy of Chris Tao, who's pulmonologist at Cincinnati. And he sent me a couple of these. And this is what happens to the lungs. There's no, in general, you can't have a lot of ventilation. All right. So what are the different risk factors for bronchiolitis obliterans? Clearly, it can do with whether they get, what type of conditioning they get, what type of prophylaxis medication, GVHD in other organs, busulfan, and some studies have shown it, bacterial viral infections. I read this, I don't know how at the male to female recipient transplant, but I would say there's something similar in lung transplant. If you transplant a female lung into a male or vice versa back and forth, they can have different outcomes in survival. So maybe there's a component of that. Prior interstitial lung disease and the form of conditioning. So survival, why is it important? Because once you diagnose BOS, the survival is worse. And so this is just showing you, in this one, this is actually from an adult population, but there are similar ones in pediatrics, not quite as robust, but this shows a Kaplan-Meier curve. And then the differences have to do with, like, if their PFTs were greater than 77%, 77 to 67, and below 77. And you can see in the lower tertile that is the highest incidence of or lowest survival rates. And this one just talks a little bit about what the higher risks are. So if it develops within the first year, if your FEV1 is below 44%, and if your FVC is below 67%. So it speaks to the rapid decline in some ways and overall survival. So that's why it's important. So now I'm going to spill the beans, just tell you about treatment, but I'm not going to spend a lot of time on it because I don't think the treatment is that good. And then I'm going to talk about how I think we can improve upon that. So the treatment in general is if you can prevent it, right? So the first few things we'll talk about prevention. From a pulmonologist standpoint, we would do things such as azithromycin FAM therapy, which is fluticasone, azithromycin, and montelukast. They're all anti-inflammatory to some degree. I'm not a big believer in it because I think it doesn't quite do what it's supposed to quick enough. I do like azithromycin as an anti-inflammatory in general, and so I will end up treating with all, but I do generally think I would not use that consideration as monotherapy. Some patients at some stages, maybe the earlier ones, will respond a little bit to high dose pulse steroids, but I think that goes away. I don't know if you guys do photopheresis here, but we've seen that it can be effective in some patients and others not quite as much. And there's other types of GVHD, so it might be better for skin and gut or as opposed to lung. TNF alpha blockade, we've used a few times in the acute setting. I'm not sure how effective that is. And then again, is azithromycin. But these are probably the better drugs that seem to work a little bit better. And what I've seen in some of the studies, in particular, the last one, the ROCK inhibitors, if they're given in the early stages of, based on their PFTs, if they only have a mild defect, they seem to work better. They have a more significant defect, they don't work as well. So I think what it teaches us that if we can do earlier intervention from a pulmonary standpoint, then we can prevent a lot of the morbidity and mortality, and that's ultimately the goal. So how do we go about that? So the diagnosis of BOS is interesting, and it's try to get it done early. So when we do spirometry, we check forced expiratory flow volumes, and the forced expiratory flow volumes are based on how much air we can blow out, and we can see how much we can blow out in a second, how much we can blow out altogether. And then this one here kind of looks at the middle fourth or 50% from, this is the peak flow would be right here, and then exhalation. So when we get to this point, that's potentially a precursor or what we learned. So the adult population has taught us that if you start as an early sign, if you see a decline in the FEF 25-75, the patients are at greater risk for the development of BOS. And this can be as early as day 80. So Anne Bergeron in France has shown that it can be predictive of it. So I have a beef with this NIH criteria for BOS, and it's essentially because it's based off of adult data. There's no pediatricians involved with it. And so, and it's inaccurate to now. So in particular, since no one uses NHANES anymore, and we all use GLI, there's some revisions that need to happen. And some of the things that we thought, this is the way lung transplant looks at it. And actually they've revised theirs a little bit, but it's a % change from the baseline, or there can be a very early precursor, which I was talking about when the FEF 25-75 drops, that's a 0.1p or 0p, and that's a good time to start thinking about it. In the, if we take the lung transplant world has developed criteria for CLAD, which includes obstructive disease and restrictive disease. And there's one study that's applied to a cohort of a couple hundred patients the 2014 NIH criteria versus the 2019 ISHLT. And the bottom line is it was a more sensitive tool for understanding if there's lung disease in general, and then if there's obstructive disease. So in that cohort, 166 patients met the ISHLT criteria, and about half of them met the NIH criteria for BOS. So again, just to bring up these points, reason why they don't work as much in pediatrics. So when we talk about the ratio FEV1 versus FVC, in adults, there's a set ratio of 0.7. But if we look at what happens in pediatrics, that same range changes dramatically from when they're 6, when it might be almost as much as they're getting 90% of the air out in the first second, all the way down to when they're a teenager, then there's a secondary. So it changes over time. It also changes by gender and ethnicity. So the current challenges that we thought for pediatrics was its reliance on spirometry. They're not using the right spirometry values. Their cutoffs are abnormal or not the right ones. It requires the absence of infection, which is not in pediatrics. Everyone has, they all have like a virus, and then it delays the diagnosis. And then omission of other testing, such as MBW or LCI and oscillometry. And then the last thing is the sensitivity of the current criteria are not as sensitive as we would like them to be. And so it also doesn't include restrictive lung disease. And so the reason why I'm talking about this is because there's a working group that's in the process of changing this. And we think the NIH criteria are not sensitive enough, and we plan to work it and develop it a little bit more. And hopefully this will be published after the new year, or it will be submitted by the end of this month and published based on a timeline probably in the spring. But what it will do is change using the GLI, which is the right normative data. It will consider adjusting relative change pre-transplant. It'll consider other testings, and it'll also give you what to do when patients can't do PFTs, because most of it's based on lung function testing. And then, like I said, more of this will come out. And the next project was, how do we follow patients with BOS? So we did a survey of different sites, and I'm sure you can understand the results. There was anything from, we don't do any PFTs, we do them every week. So this was important for us to do, to understand that we don't know what we're doing. And that led us to this next group, which is an ATS project that we're about to complete. And this was people from around, you can see North America, Europe, and Australia. And we wanted essentially the detection of bronchiolitis obliterans post-stem cell transplant. How do we do that? And so we asked ourselves 6 questions, and I'll just briefly tell you what they were. Is what do we screen first? What do we do pre-transplant? What's the routine surveillance, and what are the options for that? Can we do other testing? So MBW, and hopefully, I don't know if I'll run out of time, but I might be able to talk about that. When do you do a chest CT? When do you do a bronchoscopy? And when do you go and need a lung transplant? Or not a lung transplant, excuse me, a lung biopsy. And so this is a proposed, what I've done at the 2 institutions that I've been at most recently is baseline 3 months, 6 months, 9 months sometimes, 12 months, 18 and 24. And these are just ways to monitor over time so that we don't miss the patients who develop bronchiolitis obliterans. And the 2 sites that I've worked at recently, they've done a good job at identifying patients early on so that our treatment options are much better. And a lot of this led from, in 2018, there was an NIH workshop, and I was fortunate enough to be one of the co-chairs on that. And we talked about, this was for gaps in knowledge, and ultimately we wanted to understand what we didn't know, obviously what we don't know, and where we need to improve things. So the statement piece from the ATS was a byproduct of this. The BOS criteria change is essentially a byproduct from this. And we looked at preclinical stuff, clinical management, basic mechanisms of lung injury, long-term follow-up, and discussion to identify research disease. So out of this came changing the BO outcome. And so what we described, or what we thought would be the best way to approach this, would be to kind of understand more the natural history and collect data along the way, try to understand particular biomarkers, understand how imaging can help us. Is any kind of way that we can see that there's abnormal ventilation would be helpful. And then are there other testings that are more sensitive than the gold standard, which is essentially lung function testing. So that led us to, I was fortunate to work with Jason Woods, who's a PhD at Cincinnati, along with Stella Davies, who's formerly from Minnesota and also there, and she's a BMT doc. And we thought we'd put together, so we're funded to do a multi-center site with allo transplants, and our goal is about 1,300 patients. Anyone under 24, we'll look at, we have them grouped into abnormal baseline and normal, and then we have different events, and based on all of these, we do increase or decrease our therapy. And we're doing some novel testing with hyperpolarized xenon, oscillometry, MBW, and home spirometry. And the goal is to put all this together and then try to identify risk factors over time. And just, I'm going to skip over some of this stuff, but so to date, we're in year 2. We have about 280 patients enrolled, which is very exciting. We do different testing. So some sites do some testing, some do others. We have our preliminary results that will be presented in February in San Antonio and then at ATS. And it's nice, there's a pretty robust group of abstracts, about 10 of them from each, at each one. And some of it we'll talk, it's mostly about baseline findings so far, and if we can identify patients at greater risk moving forward. And the different techniques, and then so just to give a shout out to the Cincinnati team, they are looking at biomarkers now. So we've been able to, some of the biomarkers are proteomics, and trying to understand which ones will lead us to increased signal. And I won't go into that right now. But so one of the things that we end up doing is conventional PFTs. That seems to be the gold standard. Everyone seems to do them here. There's a good understanding of that. But lung clearance index is a way of nitrogen washout. So we give someone 100% oxygen, they breathe, and we wait and see how long it takes to go out. And that's one method that we're using. It's pretty simple. I'll just show you that I can do it. My results are abnormal, but I can do it. And we have data from another study that shows that it's a sensitive measure for studying. So maybe it's a little bit more sensitive than PFTs. And then lastly, I'll just show you that oscillometry, it's a pretty simple test. We're going to start doing it in infants also. It really gives like a sound wave when you do tidal breathing. You need to breathe for 20 seconds. And after that, we can learn a lot about the mechanics of the lungs and get different signals, so we can understand if they have a restricted pattern or an obstructed pattern. And also easy to do in pediatrics. Each test is about 20 seconds, and there's different patterns that can be done. And what I'd like to just show you, one last thing, is hyperpolarized xenon, which is a pretty cool test. They breathe in hyperpolarized xenon, and based on this, we can see areas where someone has BOS, where there's ventilation is abnormal. And it's a pretty powerful tool to see. You can also at some point see the metabolism in those areas. So there's other studies you can see red blood cell uptake and some of the micro stuff. And so those are the things that we're working on right now. All of that is within the Transpire study. We'd like to add, we have 2 smaller R01s that are off of that, and we'd like to increase it also to include auto transplants, which we're submitting for now. And with that, I would just say, this is what Minnesota looks like in the summer. And this is my bike riding, and I'm happy to answer any questions. Right. So that's a good question. So one of them is, I don't have it up and running yet, but I'd like to do oscillometry. And I think we've started, if they're in our study, we can do it. And we're doing it from age 3 and up, and that's one measure. I think I might do more CTs and more bronchoscopy in that population, and also clinically. And you know, kids are, when they don't want to run or they're tired, it's pretty easy, and you know that something's wrong. But we have one patient who's 5, he doesn't do PFTs, and unfortunately he's on, and he's been very difficult to manage, and he has signs of chronic infection along with concerns for bronchiolitis obliterans, and he's had multiple bronchs and imaging.
Sam, thank you for that talk. We have a question from the audience from Jesse Alexander, who asked, who said this was a great, important talk and stated that at the previous institution, deflation PFTs were performed. Do you have any perspective on that sort of testing in young children?
The infant PFTs?
I think that's what they're talking about.
So, I mean, that's a whole world. We don't have good testing for it right now. And a lot of the infant PFT sites are not up and running as much. Plus, it involves sedation and it involves a lot of other things. So, you know, if you're doing, some sites are doing a lot of these metabolic disorders early on and not. One of the things that we'd like to submit is there's an infant oscillometer where really they just breathe in and out. And you can do that. We're in the process of setting up a protocol for it. It's a relatively new machine. They've done some studies. Actually, they did some in BPD kids in Los Angeles. And so we haven't started it yet, but in theory, that would be one of the best ways to measure. And we're able to do it like when they go get a line placement or you can do it while they're sleeping, essentially.
I have a question. Are there any histologic or anatomic abnormalities that distinguish the stem cell transplant BO versus that which is post-infectious or post-lung transplant?
No, they're pretty similar. So it must be a common pathway. I'm sure if we had a better understanding of the mechanisms, and I think we don't really, if we look more like single cell RNA, or if we looked at different signals that we can get, sort of cytokines or whatnot, there may be some slight differences, but I still think it's probably T cell related or something along those lines. And you know, like, so in patients with lung transplant, we suppress them with mycophenolate, for example, and tacrolimus and steroids. And stem cell, I think it has to do with maybe their how they repopulate and which cell lines are expanded more. And then the adenovirus, we try to look at if we could pick up any kind of genetic signal for that. So we did a very short study, and the only thing that came out that was common was that certain groups had ADHD, which I think it was an incidental finding.
Mm-hmm. But the regional distribution, though, it's
very similar.
It's very similar, even so it's diffuse in both cases.
Yeah.
Thank you.
Well, I'd like to thank everybody for coming. I'd like to thank Dr. Goldfarb for being here. I think there's a little time if people want to catch him after rounds here. And thank you very much, Sam. That was great.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.